Question 25. You hear a surgeon reminding the theater staff about the new count check procedure before closure. Now read the question.
Listen up, team. We've streamlined the closure checklist to save time, but there's one new non-negotiable step. Previously, the scrub nurse would verify the initial instrument count, and the circulating nurse would sign the final sheet. Now, the final instrument count must be verbally confirmed by both the scrub nurse and the surgeon before the dressing is applied. We've removed the circulating nurse from the final verification entirely. This dual confirmation is mandatory for all complex procedures from this.
Question 26. You hear a nurse handing over a patient, Mrs. Kwan, to a colleague. Now read the question.
Mrs. Kwan in 1C, post-op day 1. She's doing well, no pain at arrest. Her abdominal drain output is low, which is fine. The doctor's focus is on mobilization. She needs to walk the length of the corridor 4 times today. I checked her blood pressure this morning. It was slightly elevated, 145/90, but the crucial thing is the physical therapy. She refused the 8 a.m. walk citing fatigue, so the instruction is to ensure she completes her ambulation before the midday meal. Otherwise, she'll risk post-operative complications like DVT.
Question 27. You hear a geriatric nurse specialist advising staff on hydration monitoring for elderly residents. Now read the question.
When monitoring fluid balance in our elderly cohort, relying solely on intake output charts can be misleading, particularly for those with existing cardiac issues. While skin turgor is often taught, it's not a reliable indicator in the very old. The most immediate and reliable objective sign of emerging dehydration is a subtle change in the patient's heart rate, showing tachycardia. This is much quicker to spot than sunken eyes or dry mucous membranes and allows for prompt intervention.
Question 28. You hear a pharmacist advising a patient about their new antibiotic prescription. Now read the question.
This antibiotic, doxycycline, is a highly effective medication used to treat a wide range of bacterial infections. You'll need to take one tablet twice a day for a total of 7 days to ensure the infection is properly cleared. However, there's a very important precaution you must follow during this treatment. Doxycycline can make your skin significantly more sensitive to sunlight, a condition known as photosensitivity. Because of this, you should always wear protective clothing, use a high SPF sunscreen, and wear sunglasses whenever you go outdoors, even on cloudy days. Most importantly, you must completely avoid using sunbeds or artificial tanning lamps during the entire course of treatment. Even brief exposure to ultraviolet UV light can trigger a severe phototoxic reaction, leading to redness, burning, and intense pain. Taking these precautions will help you stay safe while the medication does its job effectively.
Question 29. You hear a consultant dictating notes after a patient review for chronic low back pain. Now read the question.
Patient, Mr. Harper, 45, chronic lumbar pain. We've tried physical therapy and NSAIDs with limited success. He's asking about surgical options. The imaging reveals significant disc degeneration. I've reviewed the case and advised against surgery at this stage. Instead, I'm recommending a targeted injection. The key reason for rejecting surgery now is the lack of any demonstrable neurological deficit, such as foot drop or loss of reflexes. Until those objective clinical signs present, the patient's pain, while significant, remains manageable via conservative measures.
Question 30. You hear an epidemiologist discussing the success of a recent community vaccination drive. Now read the question.
The primary challenge wasn't public reluctance, which we managed through local outreach. Our main logistical hurdle was ensuring adequate cold chain storage capacity for the new mRNA vaccine. We had excellent vaccine supply and sufficient staff were trained, but the specialized ultra-low temperature freezers simply weren't available in all rural clinics. We had to lease additional units, which solved the problem. Without that temperature control, the vaccine would have been useless.
Part C. You will hear an excerpt from a health podcast featuring an interview with Dr. Elias Vance, a cognitive neuroscientist, discussing the nature of misophonia and its distinction from other sound disorders. You now have 90 seconds to look at the questions.
Dr. Vance, thank you for clarifying. Before we move ahead, there's one term that seems to confuse a lot of people: misophonia. Many still lump it together with general noise sensitivity. Could you unpack that difference for us?
That's a crucial distinction. There's a related condition called hyperacusis, where a person becomes hypersensitive to loudness. The overall decibel level literally hurts their ears. A fire alarm, crowded room, even a blender can feel unbearable. Misophonia, however, is fundamentally different. It's not about volume at all. Instead, it's an adverse emotional reaction to a very specific sound pattern, like chewing, sniffing, or the repetitive clicking of a pen. The patient isn't reacting to how loud the sound is, but to what the sound is. Even a whisper-level trigger can send them into the stress.
So it's the pattern of sound, not the intensity. And when someone encounters one of these triggers, what does that reaction actually look like? Is it just irritation or mild frustration?
It's far beyond frustration. What we see is a full-blown fight or flight response, a surge of panic and anger that feels uncontrollable. Patients describe it as a wave of anxiety that hits instantly. Physiologically, their heart rate spikes, muscles tense, palms sweat, and their breathing quickens. It's not a conscious decision.
So there was infection of the middle of death, without stage, infection of everything, as published everything. The thing is that shows high accurate in the cytomuscular colon area. So again, we did our right musculotomy and plan to do a validation biopsy. This was like the pretty much a procedure, but this case, in spite of taking so much effort, in spite of doing validation biopsy from the cytomuscular area, it didn't do anything. Okay, that's negative. So we put the patient on as per the research article conducted. So we started the patient on cetaprazone and tolvaptan, continuously of IV medication. And as the patient was already on voriconazole for complex bulbar osteomyelitis, that was also continued because anyway we got a negative concept. We are not sure if it's a bacteria or not. So we did it for everything. And the patient has been clearly monitored with inflammatory markers and techniques. So the final take-home message is patient with near discharge algorithm for more than 3 weeks duration, and this is a known diabetic, which is uncontrolled elderly. We have to keep eliminate automatic external in mind. So if the infection does not progress to become osteomyelitis, we will just treat the patient as a chronic autoimmune, which is very easy. Whereas if we use the patient, the longevity and mortality and morbidity is very high because 40% mortality. Okay, and ATG rate is not so clearly to ATG, which can monitor the disease progression. And as mentioned, these are introduction, which is constantly done and can be used to remove define ATG time. And the patients under constant follow-up once in 2 months or 3 months. These are the differences. Thank you so much.
Patients with diabetes, they should always have their eyes tested. I know that, of course,
around 6%, while in UAE it is around 16%. Interestingly, I find one study conducted in Netherlands in China, where around 872 new nationals were included, and they realized that failures of diabetes is around 25%, which is very high than the gold standard. And I think that the group can cause a loss of vision due to diabetes abnormality, and we have to understand that it is number one of the main cause of loss of vision among working adults. Like you will see that nowadays the main cause of blindness is abnormality and it is the disease. At present, around 10% diabetes are having some sort of retinopathy affecting their vision. That is a significant number. I found an interesting study where when the UAE in Highland district, and this they gave the new nationals around 530 patients were treated all diabetes, and they found that 74% are suffering with diabetic retinopathy, and around 90% are suffering with the diabetic retinopathy, and out of that, 3/4 or 75% patients are not aware of their diabetic retinopathy. So here comes our discussion that diabetic retinopathy needs awareness among the patients as well as the healthcare providers. When you are ophthalmologist or any such specialty, you need to know how can we certain like during the presentation. So to understand this disease, we have to start with the diagnosis and make it very basic to make it understandable for everyone. So this is a basic structure of the eye. We know that the eyeball is lined by a layer in the retina, which is photoreceptors that take the light and the visual signals and send it to the brain. The retina is made up of around 10 layers, and this is the retina and so many blood vessels. As the light falls through the retina, there is a biochemical reaction, so it needs much oxygen. So for 1 gram tissue of the retina needs maximum oxygen to the entire body. More oxygen means more blood supply. So 1 gram tissue of the retina is having the maximum blood flow in the entire body. It means there must be much blood supply on the capillaries. So in other words, in simple way, I can say retina is nothing, your retina is nothing, it is just a bunch of the capillaries which are photoreceptors. So when we are saying capillaries, we know that the long-standing hyperglycemia in the diabetes causes damage in the small blood vessels, micro and capillaries. So long-standing hyperglycemia causes damage of the capillaries in the retina, causes loss of the cell size, wasted membrane, angioedema, all that leads to loss of structural integrity of the capillaries. Capillaries at high cost. So we say it's a microaneurysm. The microaneurysm looks like a small tiny dot, red dot, and it is a long time. Once we find the microaneurysm, we can say the patient is having a diabetic retinopathy. These blood vessels sometimes rupture and cause a bleeding. If it is deep in the retina, it looks like a deep red color dot, or if it's spread on the surface of the retina, it looks like a flame shape. The flame shape can be dot formation. We can find some aggregation of the cholesterol and lipids on the retina, which is a heart disease. Ischemia on the retinal nerve fiber layer can lead to some white hair cells, which is a spotted neuropathy. So these are the cardinal signs that we see in cases of diabetic retinopathy. As the blood vessels are not, the capillaries are not structurally normal, it leads to microthrombosis, occlusion, and ischemia. Same time, there is a loss of integration of blood-retinal barrier, so the plasma exudes from the capillaries in the surrounding retina. So the leaky capillaries causes fluid accumulation or fluid cyst formation in the tissue of the retina. We can say we have a fluorocyst in the retina. So we can understand when there is water in between the layers of the retina, very get disturbed. The light is not going to the photoreceptors. But more interestingly, if the fluid remains in the eye, if it remains in the retina, or we say the center of the retina macula, it can cause distortion of the anatomy, distortion of the structures of the retina, and that can lead to permanent loss of retinal cells or photoreceptors. So here is the most important part we have to understand. Leaky blood vessels lead to fluid in the retina that disturbs the vision, but if the fluid remains for the longer duration, it can cause structural loss of the retina and cause loss of photoreceptors. These all factors try to make some coefficient that can supply the ischemic area. So we get a bunch of blood vessels on the surface. These blood vessels on the surface of the retina are abnormal, fragile. They are trying to make coefficient, but they cannot, and ultimately lead to the complication. This stage where we find some abnormal cells on the surface of the retina, we see it as a neovascularization. So these blood vessels, the bunch of the blood vessels run on the wrist, which is neovascularization at the wrist, so new vessels at the wrist. We find these bunch of blood vessels anywhere else other than the wrist, which is neovascularization elsewhere or the IV. So these blood vessels are fragile, abnormal. They can breathe spontaneously anytime inside the eye and cause the hemorrhage inside the eye, which is the vicious cavity, and this is the vicious hemorrhage. So it can lead to the vicious hemorrhage. These blood vessels can lead to fibrosis as well. So what we get in the advanced physical therapy, when there is a widespread ischemia in the retina, a bunch of blood vessels coming along with fibrous tissue. And it leads to something we can say like a scar. So blood vessels, fibrous tissue start contracting and pull the retina from the surface of the eye or the eyeball, the retina detachment. And it is happening because of the traction we see as a fractional retinal detachment. So here we get two complications because of the diabetes. One is the vicious hemorrhage and second is distortion and fraction of retina, fractional retinal detachment. That these two conditions can cause irreversible loss of vision. It is the advanced vision that is loss of vision. So this is how the diabetes starts, from high blood sugars to small microaneurysms to rupture further bleeding, drop in blood hemorrhages, clinical hemorrhages that can further lead to macular edema, and persistent macular edema can cause structural loss to the retina. White cell ischemia causes new blood vessels in the retina, which is a neovascularization, and we have known the vessels can lead to vicious hemorrhage in the retinal detachment. So let's discuss about symptoms. So how the patient perceives it. Interestingly, at the early stage, patient is having no symptoms at all. The reason is, until the central 1 millimeter of the retina is not affected or our visual axis is clear, patient has no symptoms. So patient only complains when disease is very advanced. And we know that this is disease we can treat very well, we can prevent, we can reverse the diabetic problem. So early treatment, early diagnosis is key. And here comes the role of all our healthcare providers and health educators. When we have to guide the patient that if you have a diabetes, you don't have a symptom, but you have to go for the ophthalmologist for a comprehensive eye check. So, duration of the diabetes is the strongest risk factor. If the patient is having a diabetes of 5 years, around 25 to 40% patients are having some sort of diabetes. Now, I think it increases to 85% by the end of 20 years. Poor glycemic control is the other strongest risk factor. Importantly, if the diabetes is not well controlled in the initial 5 years of the onset, it is having a long-lasting effect that the damage that happens in the first 5 years is going throughout the life. 10% decrease in HbA1c can reduce up to 40% risk for progression of pre-existing diabetes. Hypertension, dyslipidemia are the other clinically risk factors for diabetic retinopathy as well. Other than that, smoking, anemia, excessive alcohol, obesity, and nephropathy are other risk factors. So now, this is one of the most important slides for our community that all the healthcare professionals should refer the diabetic patient for the retinopathy screening, because we are dealing with something which is preventable vision loss in most active, most productive populations that is the younger age. All the type 1 diabetic patients should be sent for screening after 5 years of the diagnosis, while type 2 diabetic patients should be immediately referred for the ophthalmic examination. Most of the time, type 2 diabetic patients diagnosed with they have a hyperglycemia or cytopenia and actually undiagnosed, so sometimes they have a retinopathy during examination. We can practically see diabetic retinopathy worsening, but the gestational diabetes doesn't cause diabetic retinopathy, so there is no screening for gestational diabetes. But if the lady is having a pre-existing diabetes, it should be screened before conception or early in the first trimester. If the lady is having a pre-existing mild to moderate diabetic retinopathy, it should be just every 3 months, but any severe diabetic retinopathy should be screened every month. One more interesting aspect, the type 1 diabetic patients once they flow towards the puberty, at that time diabetic retinopathy develops and it progresses very rapidly. So it has been screening them pre-pubertal and during puberty, so when the patient is referred for the eye examination, we take this opportunity for a comprehensive eye examination. We take the opportunistic examination because diabetic patients are prone for the glaucoma, for the cataract, and for the blue lens as well. So we do a comprehensive examination where we check the vision, the refraction, the eye pressure to rule out glaucoma. We do a complete diabetic fundus examination. If we check the patient without dilatation, our pupil is quite small, so we are able to check the limited area of the retina. But when we dilate, we are able to see more clear, more detailed analysis. Then we go for standard fundus picture. So when we ask for the dilation to the patient with the new silence, it means patient needs to wait for 1 hour, we give some eye drop, and after the eye drop, patient is not able to drive, and we do the reading work for around 1 hour, around 5 to 6 hours. So it is something which is very inconvenient for the patient, but thankfully we are having a newer modality. We have non-mediatic cameras where without dilatation we can see the pictures. So the normal standard camera can check around 45 degrees of the temperature in the retina, but the newer wide field retina imaging can take almost 20 degrees inside the eye, we can say anti-line of the retina in a single place. And in our hospital we have a ultra wide field technology where we can check the fundus picture screen the patient without dilatation and it just takes few seconds and we get a very clear wide field image for the documentation is clear. So the other more, if we doubt that the patient is having some sort of leakage or some macular edema, the next important investigation is optical coherence tomography. So retina is made up of 10 layers. This is the OCT layer, and it is a histopathology where all the 10 layers are clearly demonstrated. So you can see here, this is the histopathology, but our investigation OCT even is a better clear image. So it is a live biopsy of our retina. We can find a small cyst and we spectral disorganization in the retina at a very early stage. The another important investigation is fundus fluorescence angiography that we reserve for only advanced cases. We don't use it as a routine. Here we give, as the name suggests, fluorescence angiography. We give a fluorescent dye, sodium fluorescent dye, ultravioletly in the eye. With the blood flow, the dye goes in the retina, and we see how the blood is flowing, where the blood vessels are broken or leaky, or where the abnormal bunch of the blood vessels, no vascularization, and where is the capillary dropout, where the retina is ischemic, and what is the extent of ischemia. So by this single test, we get to know abnormal broken blood vessels, their extent, the pattern of leakage, abnormal blood vessels, and the amount of ischemia inside the eye. So These both conditions can coexist with macular edema. So diabetic again divided as a no diabetic macular edema or central involving diabetic macular edema or non-central involving. So very important to understand. If the fluid on the tip is coming right in the 1 millimeter of the retina, we say it is central involving and that means immediate treatment. While fluid clusters are there far away from the center, though reasonably, but it's not affecting the vision, we can just observe them. So macular edema can be divided as central involvement and non-central involvement. It can coexist with non-proliferative retinopathy or with proliferative retinopathy. So non-proliferative retinopathy doesn't require any treatment. You need to just control the systemic parameters. Proliferative retinopathy needs treatment. Macular edema, which is the main cause of loss of the vision among working age group, needs treatment. And in last 25 years, there is a much advancement in this treatment. There are certain protocols, certain strategies, which is quite confusing and sometimes is not very clear. But thankfully, American Society of Ophthalmology have made some guidelines which is very practical, very precise, though very complicated as well. That gives us clear-cut strategies and ideas of how to treat the diabetic macular edema. So further discussion would be based on American Society of Ophthalmology, which is guideline for the diabetic macular edema. So as we understand the fluid state which is coming to the retina because of the leaky blood vessels, because of the broken blood retinal barrier, because of the hyperglycemia, which is causing microinflammation, can lead to disturbance in light perception. The surface is not that even, light which falls on the retina is not going to the photoreceptor, it causes blurred vision. Same time, persistent fluid in the retina causes disorganization of the retinal layer and causes problem with loss of photoreceptor. So this macular edema is treated on the prior eye. So any patient who has a slight reduction in the vision, like vision is normal is 20 by 20, slight reduction 20 by 30, normal thickness on the macula is around 300, but if it is more than 300, we should treat. Even the patient who has symptoms and vision is better than 20 by 30, we should treat. Even if the thickness is slightly less than 300, we should treat with the patient. Earlier, when treatment and really time went back, when our patient with the diabetes did not come to us for the first time, we say that since you are coming for the first time and you have uncontrolled diabetes with the pressure and the cholesterol, just control your systemic parameters first. Come after 3 months, then we will reassess and start for the treatment. But this approach has changed now. Now, the American Society of Ophthalmology clearly suggests that whenever a patient comes with the macular edema, irrespective of the systemic status, we should start the treatment. Because we know that the persistent fluid in the retina can cause permanent diabetes. So we need to control and optimize the diabetes actually even in hypertension and disease. But we have to start the treatment at the same time. There is no room for observation and treatment. Sometimes until the patient is stop smoking and will stop, and we have to look for the inner diabetes. So whenever there is central involving diabetic macular edema, we give one injection inside the eye. We say the intravitreal injection, and this injection is anti-VEGF, anti-vascular penicillin growth factor molecule. These molecules are monoclonal antibodies. They are targeted against the receptor of vascular penicillin growth factor. They are certain FDA-approved anti-VEGF molecule, which is approved in many areas. These are the ranibizumab, aflibercept, rozanolixizumab, and faricimab. Other than anti-VEGF, since we know that chronic ischemia is a throat and inflammatory condition, so in the patient where we cannot give the anti-VEGF, we can give steroid as well. So we have some steroid implants that control the inflammatory reaction inside the eye because of the diabetes. These are the dexamethasone and fluticasone. So, as we understand, the central involving diabetic macular edema, we give one injection inside the eye. Because of the diabetes, these are the dexamethasone and fluticasone. So, Earlier we were talking about the prevention of loss of the vision, but now we are talking about regaining the vision, stabilization of the vision, and more importantly, more interestingly, reversal of the diabetic retinopathy severity. So with the new advancements specifically for the anti-VEGF injection, we can control this disease very effectively. These anti-VEGF injections are given inside the eye with 30-day delivery, 4 millimeters from the business on the sclera. We do an operation theater in the sclera environment. This medicine is directly given to the business cavity. The medicine works directly on the surface of the retina, and the systemic absorption is very less, so having a very few or unknown any systemic side effects of this medication. We are very targeting monoclonal antibodies. These medicines works for around 4 to 6 weeks. So we have to repeat the injection. So that is the real challenge, that as you know, the diabetes is a lifelong disease, and that retinopathy is also a lifelong disease, and similar time insulin is the control of sugar. Similar injection inside the eye is the control of retinopathy for the lifelong. So it works somewhere from 4 weeks to 8 weeks. So you have to repeat. So I have this question, maybe I'm talking to good patients or maybe family members also, that they are having diabetes and eye doctor is saying for the injections. But how many injections? They say you have to do multiple injections and you don't get any idea how many injections you have to get, and that through the whole eye. So this study was done in the old study in 2016 when first generation anti-VEGF injections were used. So they told that in first year we need to control diabetic retinopathy aggressively and around 9 injections were given in each eye. But after first year, requirement for the injections were reduced dramatically. Second year 3 injections, third year 2 injections, 1 year 1 injection, fifth year no injection at all. And the patient maintains a good vision. So in simple terms, if the patient is having a diabetic macular edema, we have to give injection in the initial 6 months more frequently, and later on after 6 months we give injection as and when required, and the requirement for injection reduces dramatically, maybe 2 or 3 injections per year in the later years. Due to latest study, which is done in the recently published in July 25, where Aflibercept 8 milligram was studied. So they find that at the end of 3 years of the treatment, around 90% of the patients were maintaining injections more than 3 months. More interestingly, around 50% were patients were taking injections at least 5 months. And 25% patients are taking injections 6 months. They have 1-2 injections in a year, and the diabetic retinopathy is well controlled, provided at the beginning, at the initiation, we have given the full dose and we have maintained very safely. There is another concept of focal vision when the macular edema is not in the center but in the periphery, or both coexist. We can do some measure to burn the leaking blood vessels. So when we burn the leaking point, the requirement for anti-VEGF injection reduces a lot. So we do this procedure in the OPD, taking light and specialized. We place the lens on the eye surface on the eyeball, and we direct the laser light directly on the leaking blood vessels that we know is the source immunity. So in this patient you can see that this was the ring of the lipid and the cholesterol coming because of the leakage, because of the macular edema, and after 4 months of the laser, the macular edema dissolved and are absorbed by the body. So this is one real example. A patient had a diabetic retinopathy, and you can see this leakage. This leakage are the focal leakages with the macular edema in the center. So we gave 2 injections. This to resolve. So 2 injections in the whole eye with 1 month interval. At the end of 2 months, we did the focal laser, and all the edema resolved and patient didn't need the injection further. So we have to give precise, customized treatment to the patient. It is not like we give injections throughout the life. There is a requirement to give the injection